Thank you, Bernardo. Thanks to the organizers for this invitation. My name is Rajinikanth Rajagopal. I'm from Pondicherry. You see the picture on top here, and I work in Brunei at the moment. That's the picture at the bottom. I'll be talking about the role of intracoronary imaging and instant restenosis. All right. This graph shows the rates and trends of instant restenosis and other skin failures over the last 20, 30 years. You can see there is a big drop in the incidence of ISR when we moved from BMS to the first generation drug-eluting stents, and then to the second generation drug-eluting stents. After that, the biggest drop in ISR was when we had imaging-guided PCI, and you can see that here. Sorry, let me get the laser pointer working. Okay, so there. And it's not surprising, we know from a lot of studies now, from long-term follow-up and large trials, that imaging-guided PCI in de novo disease improves outcomes by improving our vessel preparation, stent sizing, optimization. And if you think about ISR, all these mechanisms still work, but you literally have an extra layer. And that is the role of imaging in understanding the mechanism of failure, which will dictate our treatment. So that is what we're going to talk about for the next few minutes, how to identify the mechanism of stent failure by imaging to help us guide our treatment strategy and optimize treatment. The bottom line is the best time to do imaging is before you get ISR. So get it right the first time, but if you don't, we should get it right the second time. So this is the kind of thing we see with ISR on imaging. I won't go into too much detail, but broadly, if you look at the images, the OCT images on the left, starting from the first one, it can show us the calcium behind the stent struts that leads to underexpansion. It can show us stent fracture, where you see no stents on one side and the green lines of the stents, or two layers on the left side. And here you can see a well-expanded stent, but a lot of neo-intimal hyperplasia. So you have the OCT images in the cartoon depiction here. And here you have a well-expanded stent, but you have neoatheroma with lipid pools. And you see similar images on the right side with IVUS. For example, on the right extreme, you see neoatherosclerosis with calcium on the IVUS. But if you see these images on the angiogram, all you can see really is luminal stenosis. You will not be able to see the mechanism, and therefore we travel blindly when you do PCI with just balloons. And is there evidence to support imaging in ISR? Very little, actually. We do not have any large randomized controlled trials. Small studies like this, the RIPS-3 study, for example, in that about 38% of patients had IVUS, and in these patients you had a larger acute gain and a larger minimal lumen area at 9 months, but it did not reduce TLR at 3 years. In another study, the IOPEN ISR, about 1,500 patients, IVUS was used in about 2/3 of the patients, and in these patients you had less MACE compared to angiographic guidance at 1 year. But again, they were similar at 2 or 3 years. There were limitations to these studies, mainly because imaging was used at the operator's discretion. There was no systemized protocol to use imaging or the PCI itself. So we have lots of classifications of ISR. This is probably the most relevant one clinically and the most recent one by Waxman. So it has a lot of the 5 different classes of ISR. I think the most important to understand would be the first 2. If you see ISR these days with imaging, we should look at it as either mechanical or biological. And mechanical includes underexpansion and stent fracture. A couple of other things will come to it. And there are biological problems. And once you identify the mechanism, you can choose the right treatment option. And in reality, though, quite often we see a mixed pattern, a bit of mechanical problem and a bit of biological problem. And once we identify it, we can choose the right combination of balloons, stents, or DCBs to treat them. So to understand what we see on OCT or IVUS, we should understand the pathology. So first we look at mechanical factors. The most common by far is underexpansion. So during the initial index procedure, if the stent was not fully expanded, it leads to ISR in the future. And that could be either because of low deployment pressure when you deliver the stent on post-dilate, or because of calcium behind the stent struts, which has not been adequately prepared. The other causes could be undersizing a smaller stent in a big vessel, stent recoil, stent fracture, and geographical miss. And there are some illustrative pictures on the right where you can see the vessel is quite big and the stent is far, way away from the EEL, and therefore it's clearly underexpanded. The other slightly difficult and harder one to understand is the biological factors causing ISR. So broadly, we think about neo-intimal hyperplasia and neoatherosclerosis. Neo-intimal hyperplasia happens within the stent. So if you look at the picture here at the bottom, That is the plaque from the de novo artery before the stent was put in. The blue line is a stent. And neo-intimal hyperplasia is a completely separate pathology, not an extension of the original atheroma. It occurs after the stent's been put in reaction to various factors such as polymer and metal, and inflammation mainly. So what you have is tissue proliferation, a lot of vascular smooth muscle cells, and extracellular matrix. And this appears as neo-intimal hyperplasia. On top of that, if you have lipid pools, that usually starts with the arrival of foamy macrophages, which can lead to lipid pools and a necrotic core, that becomes neoatherosclerosis. And you can have just lipid pools, or you can have just calcification, or a combination. Anything other than simple tissue proliferation could be labeled as neoatherosclerosis. So you have a homogeneous neo-intimal hyperplasia, and if you have calcium or if you have lipids, it's neoatherosclerosis. That's a very basic way to understand the pathology and the OCT or the IVUS interpretation. And here you can see histopathology comparison with OCT. The neo-intimal hyperplasia is homogeneous, bright, uniform layer, whereas neoatherosclerosis is heterogeneous, and you can see calcium and sometimes lipid pools. In stent under expansion, again, you see the stent itself is not fully expanded, on top of which you have tissue proliferation, you have neoatherosclerosis as well. As compared to the two on the left, where the stent is good, but it has got tissue problems. So once you understand this, you put them together, and there are various algorithms to guide your treatment. This is what I practice in my everyday sort of in the lab. So when I look at in-stent restenosis, do imaging first, and I call it either mechanical or biological. If it's mechanical, try to understand the mechanism on OCT. Under expansion is the most common, or undersizing, maybe stent fracture. So if it's under expansion, I start with an NC balloon. If it is not adequate, I go for an OPN balloon. If there is calcium behind the stent struts, we can use IVL. And similarly, for undersizing and stent fractures, stent NC is usually an F. If the stent is really small, you just got to break it up with an OPN balloon, put a new stent in. Reassess, and then finish with a DCB whenever possible. Stents only if you have really exceeded the expansion limit of the previous stent, then you have to put a new stent in. For biological problems, a scoring or cutting balloon for neo-intimal hyperplasia. If it's neoatheroma, you look at if there is much calcium. If there's a lot of calcium, you have to think about cutting balloon, IVL, and rarely rotablation. Reassess with imaging or angio, and finish with the DEB mostly, but DES if there is significant residual stenosis or flow-limiting dissection. I have time, 2 minutes. I'll just do maybe one case example. Very simple, straightforward case. So this is a middle-aged man with NSCEMI who had PCI to circumflex in OM. He had bystander disease in RCA. He had previous stents about 10 years ago. He came back for stage PCI. We looked at the distal RCA lesion, which you can see here. That's to be absolutely sure is significant. We did FFR, RFR actually, that was positive significantly. So we proceeded to PCI. We did imaging first, and that showed a bit of both. So the biological problem here was neoatheroma. You can see initially there is a lot of bright plaque here that looks like this neo-intimal hyperplasia, but behind that you can see lipid pools, and calcium is very mild, not much, but it almost looks like a TICFA here with a lot of macrophages and shadowing behind that. The mechanical problem, we could see, that if you look carefully in this OCT image, you can see two stent layers. And there's always going to be a problem because that's often the focus of ISR. So we did some PCI, 3.5 NC balloon, did further imaging, and the balloon was underexpanded. It was significant residual stenosis, and it was exactly at the point of the two stent layers. So we then used an OPN balloon to dilate that. We got a good inflation, and we got a good final result. Okay? So we identified the mechanical and biological problems, and we optimized the treatment to get a good result. We won't do the second case example. Instead, we'll just summarize a very interesting case, but another day. Okay, to summarize, I'm just going to put the algorithm back again because that really, we need to use imaging, and we need to tailor our treatment based on the imaging findings. So we do imaging, identify the mechanism, treat appropriately, and optimize the final result using imaging findings. Thank you very much. We've got some pictures here of Pondicherry, the right side, and Brunei. This is Brunei, so welcome to visit us in Brunei or Pondicherry when you get a chance. Thank you very much.
Thank you, Raj. Very, very elegant lecture. With the last slide is the best one, I have to say.
Thank you.
So, do we have time for a question? You're escaping. Don't escape. Just a small comment, because this is very important. You said that for ISR we should always use imaging. That's okay. But a good message is also that people should take their time to interpret and understand what they are looking at. So you should waste a little bit more time to understand, because we already have a failure of a stent that we previously implanted. So let's try not to go in the same direction.
I completely agree. I've seen cases where they do IVUS and say, okay, this is a minimal lumen area. That's not enough with ISR. You have to go into the morphology and tailor your treatments. I completely agree with that. Thank you.